This webinar is entitled Chemotherapy, Bone Strengthening Drugs, and Oral Care. How are they related? With Dr. Lauren Levy. The webinar was recorded on June 22, 2015. Listen in while Share Breast Cancer Program Director Christine Benjamin introduces Dr. Levy.
Trained in dental oncology, Lauren Levy is a general dentist who provides care to cancer patients and is committed to delivering comprehensive oral care. She has extensive experience treating patients who are receiving chemotherapy, radiation therapy, and stem cell transplants, and who face individualized dental needs because of these treatment programs. Dr. Levy received a Bachelor of Arts in Psychology from Barnard College of Columbia University. She obtained her Doctor of Dental Medicine degree from the University of Florida College of Dentistry, where she received an award for excellence in oral medicine. In dental school, Dr. Levy was actively involved in community outreach, delivering dental care to indigent populations in Florida and central Ecuador. After graduating, she completed a general practice residency at New York Presbyterian Weill Cornell Medical Center. Dr. Levy completed a dental oncology fellowship at Memorial Sloan Kettering Cancer Center after her residency. She has expertise in assessing and managing the oral manifestations of head and/or neck surgery and osteonecrosis of the jaw. Her areas of focus also include caring for pediatric patients, managing patients with solid and liquid tumors, and treating other non-malignant oral pathological conditions. With her knowledge of both the physical and psychological effects of cancer on patients requiring dental care, she is dedicated to enhancing the lives of cancer patients. Dr. Levy, thank you so much for being with us today. I'm going to turn it over to you.
Great, thank you for that introduction. Okay, so I guess I'm going to get started. So this lecture is entitled Chemotherapy, Bone Strengthening Drugs, and Oral Care, How Are They Related? So in this lecture, I'm going to talk a little bit about what dental oncology is as a discipline, why it's important for a cancer patient to visit a dentist during their cancer treatment, what the dentist should be told about your cancer treatment, as well as what the dentist should discuss with the oncologist, when it is safe to visit a dentist during cancer treatment, how chemotherapy affects the mouth, what are bone strengthening drugs, and how are they related to oral care. Sorry about that. Okay. So what's dental oncology? Dental oncology is an area of dentistry focusing on the dental and oral manifestations of chemotherapy, radiation treatment, and/or head and neck surgery. Dental oncologists work with the oncology team to enhance the patient's quality of life before, during, and after treatment. And the treatment involves not only treating the dental effects of cancer therapy, but also treating the soft tissues and the overall oral environment. Why is it important to visit a dentist during cancer therapy? Believe it or not, oral complications associated with cancer therapy are extremely common, and there have been studies that suggest that poor oral health may be linked to an increased incidence and severity of oral side effects. So it's recommended that cancer patients visit a dental oncologist before undergoing cancer treatment to help reduce the risk of developing oral side effects and oral infections that may otherwise halt cancer treatment. So we'll go over these oral complications a little bit more in detail, but just as an overview, some very common oral complications of cancer therapy include mucositis, also known as mouth sores, infections which range from being bacterial, viral, or fungal, dry mouth, and along with dry mouth, alteration in the sense of taste, and other effects which I will talk about and are more related to the bone strengthening drugs, but osteonecrosis of the jaw. So when you go visit the dentist, what should the dentist know about your cancer therapy? It goes without saying that no matter what your medical history is, whether or not you have a history of cancer, that you should disclose all of your medical conditions to your dentist, as some of the dental treatment that may be performed may be altered based on the medical conditions that you have. So it's obviously very important to tell your dentist if, for example, you have a history of surgery to your heart or a history of joint surgery. And when it comes to cancer, the more information, the better. So you want to tell them your cancer type and stage. If you know your complete blood counts with differentials, give them that information as well. If you're going to be undergoing head and neck radiation treatment, where will that be and when, as well as when will it start? Any previous cancer therapy, and if you have a history of anti-resorptive medications, the bone strengthening drugs that we will talk about in a little. After you have visited your dentist, what should your dentist tell your cancer doctor? So your dentist should tell your oncologist if you have a history of, if you have any cavities and any treat that may require work before undergoing cancer therapy, and any signs of any sort of infections in the mouth, and any teeth that may require extractions. I think it's important to mention that when you're going to see your dentist before cancer therapy, there's a few important goals that should be done at that visit. We want to eliminate any source of infection, and we want to stabilize any oral disease that might be present in the mouth. This isn't the time to do aesthetic work. This isn't the time to be doing a full mouth reconstruction. However, if there are looming infections in the mouth that may otherwise pose a problem while the patient is in the midst of treatment, this is the time to stabilize those infections, stabilize that whatever is going on in the mouth, and eliminate that infection. So if that infection can be eliminated through root canal therapy, through extractions, and often if patients are wearing orthodontic braces or appliances, it's recommended that those are removed because braces can harbor a lot of bacteria and it's very hard to clean them, and that could also potentially act as pose a source of infection. So this is more just a general slide, dentistry 101 slide, which I think is really important to review the difference between invasive and non-invasive dental procedures. Invasive dental procedures are dental procedures that, for lack of a better term, induce bleeding. So these include extractions, gum surgery, or implants. The reason I distinguish between invasive dental procedures and non-invasive dental procedures is because invasive dental procedures require a healing time. Non-invasive dental procedures do not. So if you need an invasive dental procedure performed before therapy, traditionally 2 weeks is the time period where you would want a 2-week time period of healing prior to starting any sort of cancer therapy. Non-invasive dental procedures, however, which include fillings, root canal therapy, crowns, bridges, or removable dentures, do not require a healing period. So those could be done, and then the treatment could be started the next day as long as that non-invasive dental procedure is complete. Again, though, as I was saying before, you don't want to be doing any sort of dental work that is not absolutely necessary to. So ideally, implants are usually more of a elective procedure, so they would probably not be done before, but just for thoroughness, I include them on this slide. Okay, so cancer treatment Cancer treatment that is associated with oral side effects includes chemotherapy, stem cell transplants, radiation treatment to the head and neck, anti-resorptive medications, head and neck surgery. This lecture is going to focus on chemotherapy and anti-resorptive medications. Are there certain blood counts that are safe or not safe for dental work? Of course, ideally when you come to visit the dentist, we would like for all of your counts to be within normal limits, but the counts that are most important are platelets and neutrophils. The platelets are the cells in your blood that are responsible for clotting, and in other words, to stop bleeding. Neutrophils are white blood cells that are important to fight against infection. We want the two most important numbers, as I said before, are the two most important blood counts that we need are the absolute neutrophil counts and the platelets. We want the absolute neutrophil count to be at least 1, and the platelets to be at least 50. If the absolute neutrophil count is less than 1, it's really not recommended that any dental work be performed. If there is an emergency and it absolutely needs to be performed, then I would recommend that your dentist and oncologist coordinate when would be the best time to be, if your counts are going to go up anytime soon, to maybe wait. If they're not going to go up and it's an absolute emergency, then antibiotics administered before would be recommended. As for the platelets or the blood clotting cells, the minimum number, as I said, is 50 before any sort of invasive dental work. In other words, before an extraction, before an implant, before gum surgery. If it's absolutely necessary and something needs to be done when the counts are below 50, then a transfusion might be, is usually the best option. And you would want to take blood work after the transfusion to ensure that the platelet count has actually increased. So some side effects associated with chemotherapy, which I will go over more. Mucositis, oral infections, taste alterations, dry mouth, neuropathies, and excessive bleeding from the low platelet counts. Mucositis. Mucositis is the same thing as mouth sores. It presents as redness followed by white sloughing ulcers, and it affects up to 40% of people that are undergoing chemotherapy. It's usually seen 2 weeks after undergoing high-dose chemotherapy, and it usually affects the tissues in the mouth that are called movable mucosa. In other words, the softer stuff in the mouth, for lack of a better term. So your cheeks, obviously the inside of your cheeks, your tongue, floor of mouth, soft palate. It's not as common, although it can be, on the hard palate and the gums. So like I said, anything that's very movable in your mouth. Usually, though, the good thing is that it usually resolves once your counts improve, specifically that ANC. But once all those white blood cell counts improve, mucositis usually goes away. There is some research that states that going to see, there is some research that states that seeing a dentist prior to undergoing chemotherapy may reduce the duration of mucositis. So how do we manage this? Prophylactic measures cannot be emphasized enough. I always recommend that people visit their dentist before, like I said, before undergoing chemotherapy, so that to get a cleaning and to have your mouth at a stable baseline, and continue practicing good oral hygiene throughout undergoing therapy. Avoiding spicy, hot, and acidic foods and using a mild toothpaste can also prevent aggravation. Additionally, keeping the mouth extremely clean, not only through brushing your teeth and flossing, but also through bland rinses with saline and sodium bicarbonate together. So a little bit of baking soda, a little bit of salt, put it in a glass of water, mix that around, swish and spit 3 times a day. If mucositis does arise, there are several over-the-counter mucosal coating agents that can be used. These are more palliative. They don't actually treat mucositis, but they more just make mucositis bearable, and they kind of just numb up the mouth a little bit. There's also something called magic mouthwash, which your dentist or oncologist can prescribe for you, and it's kind of a cocktail of a few different drugs that can numb up your mouth so that it's more comfortable to eat. I also a lot of times recommend milkshakes. Those coat the mouth. They feel really good. Obviously taste delicious, so it's a good, that's another option. Oral infections. These occur most commonly during the times that the blood counts are extremely low. Bacterial infections specifically really only occur secondary to mucositis ulcers. Oral infections usually present looking like canker sores. And I wrote here that they may also, which is true, sometimes these canker sores can actually also be the result of certain drugs. Fungal infections are also very common. They're very commonly associated with dry mouth as well, and they often kind of look like thrush or like a cream cheese almost on your mouth. And viral infections, when counts are low, patients are at an increased risk of viral infections. However, many patients are already on antivirals, so the risk of getting these is lower if you're on antivirals as a prophylactic measure. Treating these oral infections is pretty straightforward. Like I said before, oftentimes these infections are not really that common if you are on prophylaxis. If not, antivirals can be treated, viral infections can be treated with antivirals, fungal infections can be treated with antifungals, and I think it's always important to note that if you are wearing a removable appliance such as a denture or a retainer or mouth guard, something, make sure that you soak that in an antifungal medication as well overnight. If that's not done, then you'll just continuously reinfect yourself with the fungus. So if your oncologist is writing you this medication, make sure to remind them, oh, I wear a denture. Should I treat that as well? And same thing as if you are your dentist, who would hopefully be treating your dentures, but if for some reason they forget, remind them. Neurotoxicities. So this is actually a very interesting side effect. There are certain chemotherapies that can actually result in phantom tooth pain or throbbing jaw pain. These chemotherapies, which are known as vinca alkaloids, so these are like your vincristine, your vinblastine, these drugs are associated with peripheral neuropathy, which is that tingling sensation that you can get in your digits and toes. And for some reason, the way that it manifests in the jaw is it manifests as a toothache. So patients may present to their dentist. I've seen patients present saying, my tooth hurts. I'm convinced that I have that I need a root canal. And they go in and you take an X-ray and everything looks completely fine. And only after you ask several questions do you find out that they're actually taking these vinca alkaloids, and that's the reason for their discomfort. So the good thing about this is that this throbbing tooth pain actually goes away once the chemotherapy stops, but it's really important that you give your dentist a thorough history, because if you don't, you could end up getting a root canal when it's not necessary, and then unfortunately the pain still won't go away. Dental hypersensitivity may also arise, but again, this hypersensitivity does go away once the treatment is over. So as I said before, visiting dentists to get a thorough exam and giving a thorough history is extremely important. And as for the hypersensitivity, applying fluoride or a desensitizing agent can really help. So using Sensodyne and maybe even a prescription strength toothpaste can help. Bone strengthening drugs. So what are these bone strengthening drugs? Bone strengthening drugs are often prescribed to patients with multiple myeloma, metastatic disease to the bone, including breast or prostate cancer, bone cancers, or several other bone conditions, including osteoporosis or osteopenia. It's basically a broad colloquial term to describe anti-resorptive medications. Specifically, the ones that I will discuss include bisphosphonates, denosumab, bevacizumab, and sunitinib. Bisphosphonates is a huge class of drugs that includes Zometa, Aredia, pamidronate, Boniva, Fosamax. Denosumab is usually either called Exgeva or Prolia. Bevacizumab, the trade name is Avastin, and sunitinib, the trade name is Sutent. Bevacizumab and sunitinib are less commonly associated with this oral condition that I'm about to discuss, but there have been a few reported cases, and that's why I've included them. Okay. So to summarize anti-resorptive medications, they are medications that alter the normal functioning of bone cells. And these drugs, the reason that this is significant is they may be associated with a condition characterized by abnormal wound healing known as osteonecrosis of the jaw. all of these drugs, their mechanism of action is different. I just put them all classified into the same category because they are all associated with osteonecrosis of the jaw, but they are otherwise not similar pharmacologically. They don't have the same mechanism of action, they do not have the same half-life. There really isn't anything else similar about them. They're not even all used for the same condition, although denosumab and bisphosphonates are both used for bone, I mean, I guess they're all used for bone conditions, but that's it. Okay, so what is osteonecrosis of the jaw? According to the American Society of Bone and Mineral Research, osteonecrosis of the jaw is an area of exposed bone in the head and neck region that persists for greater than 8 weeks in a patient with no known history of radiation to the jaws. Some signs and symptoms of osteonecrosis of the jaw include exposed dead bone, a non-healing ulcer or wound, numbness or tingling in the mouth, a draining abscess or fistula, swelling, foul odor or bad breath. It may or may not present with pain, and in severe cases, fracturing of the jaw may result from osteonecrosis of the jaw. Basically, if I had to summarize osteonecrosis of the jaw, I would say it's a non-healing ulcer or wound that may or may not present with pain and may or may not present with exposed bone, but usually you can find that exposed dead bone. It may or may not present with pus. So some risk factors include trauma to the jaw, and when I say trauma to the jaw, specifically I mean usually through manipulation of tissues in a surgical respect. So through some sort of gum surgery, extractions, or implants. Some sort of dental invasive surgical procedure. That is a huge risk factor. Unfortunately, having teeth, believe it or not, is a risk factor, but that's only a risk factor because if you have teeth, you may have these dental surgical procedures. The dosing of the drugs, so the more doses of a bisphosphonate that one has or denosumab that one has, the greater risk of osteonecrosis of the jaw. Having gum disease, having poor health or nutritional status, and specifically also having poor oral health, because that puts you at greater risk for infection in the mouth. So the true incidence of osteonecrosis of the jaw is unknown. The estimated cumulative incidence ranges all the way from 0.7 to 24.5, which I realize is a huge range, but I think that's because we really haven't been working with bisphosphonates for all that long, and so it's very hard for us to really determine when osteonecrosis of the jaw has started, what it has started from. So for the most part, I would say that the incidence is low, but it's important that patients always have as most information that they can have regarding this, because even if the incidence is low, I like to equate it to walking across the street at rush hour. You know, the risk of getting osteonecrosis of the jaw might only be 1% or 3%, but if you, so like walking across the street and getting hit by a car, your risk might be, 0%, but that one time you get hit, it's 100% to you. So it's best to always be cautious. So osteonecrosis of the jaw can be associated with bisphosphonates, denosumab, rarely Avastin, rarely sunitinib. Is there a difference between bisphosphonate-related osteonecrosis of the jaw from denosumab-related or Avastin-related? There are studies saying that there's a higher, there have been some studies saying there's a higher incidence associated with denosumab, higher incidence related to bisphosphonates. For the most part, I would say that the incidence seems to be similar. And what other differences might there be? Well, as I said before, the mechanism of action of all these drugs is different. Bisphosphonates have an extremely long half-life, and what does that mean? That means that the way that we measure how a drug is in the body is by half-life. Half-life is when half of the drug is gone. So bisphosphonates have a half-life of 10 years. In other words, in 10 years, half of the drug, if you take the drug today, in 10 years, half of it will still be in your system. So why is that significant? It's significant because if you have taken several doses of bisphosphonates and you decide, okay, well, I'm going to go off the drug, I guess I can get, that invasive dental work that we were talking about before. Is that okay? No. The answer is it's not okay, because in 10 years, half of it's still in your body. So even if you stop taking it after having several doses, the likelihood that it's out of your system is low, and so you're still at risk. Deneuvem has a slightly shorter half-life, but it's a relatively new drug, and until we know more, even though it might be out of your system shorter, I still would say, even if you have stopped taking deneuvem, I would still avoid dental procedures that are invasive. So I would still avoid, any sort of dental surgical procedures. So what does this all mean? Well, regarding incidence and prevalence and which drug is the culprit, there are few cases reported where patients have only been exposed to one of the drugs that I'm talking about. Well, bisphosphonates, that's not true. There are several reported cases of bisphosphonate-related osteonecrosis of the jaw. But besides bisphosphonates, there are a few cases reported where they've only been exposed to denosumab, bevacizumab, or sunitinib. So it's hard to determine which drug actually caused the osteonecrosis of the jaw. Nonetheless, they're all associated with osteonecrosis of the jaw, so we have to be cautious if you've taken any of these drugs. So how do we treat it? Maintaining excellent oral hygiene is extremely important. Using oral irrigators, in other words, keeping the mouth clean with antimicrobial rinses, with warm salt water, baking soda, not smoking, but that goes without saying, and visiting the dentist frequently to get checkups and to make sure that there are no cavities or areas of looming infection. Dental extraction should be avoided. I can't emphasize this enough. Like I was saying before, osteonecrosis of the jaw is mainly associated with trauma to the jaw. So it's mainly associated with, and you can think of an extraction as as trauma. So it's mainly associated with some sort of dental surgical procedure. So extractions, implants, gum surgeries. If you have taken these drugs or you're on these drugs, any dental surgical procedures should be avoided. Non-invasive dental procedures are not contraindicated. But if you are told that you're going to be starting any of these drugs, before starting, any questionable teeth should be extracted or restored 14 to 21 days before to allow for adequate healing. And then going forward, it's really important to tell your dentist, hey, I'm on bisphosphonates, hey, I'm on denosumab, so that they can avoid any sort of invasive dental procedures and minimize trauma. So that means a root canal over an extraction, or a root canal over, or basically avoiding anything where there will be excessive bleeding, where the bone might be disrupted. I also should mention, and I don't think I mentioned this, that osteonecrosis of the jaw can occur spontaneously, unfortunately. The risk of it occurring spontaneously the incidence is much lower, but it can occur spontaneously. I also think I should mention that bisphosphonates come in two forms. They can be IV or oral. The incidence of osteonecrosis of the jaw is much higher. It's much more likely associated with IV drugs, not with oral. 96% of osteonecrosis of the jaw, bisphosphonate-related osteonecrosis of the jaw is most of the time associated with IV administration, 96% of the time. Only 4% of those cases are orally. So that's another thing that's really important to tell your dentist if it's IV versus if it's oral. What about the fact that some of these drugs have half-life shorter than bisphosphonates? There is some literature suggesting that drug holidays may be more successful with these drugs, but it's questionable. I still would go on the side of caution. With Sutent and Avastin, the risk of osteonecrosis of the jaw is very, very, very low. So if you're only taking those drugs, then maybe a drug holiday would be a good idea. I think that would be something to really discuss with your oncologist and your dentist before. I don't want to make any general statements. However, a drug holiday with bisphosphonates or denosumab, I would still, even I would still be cautious no matter what, and avoid any sort of invasive dental procedures once you've been on these drugs. So what are the take-home points? During cancer therapy, routine oral hygiene is essential for minimizing the severity and incidence of oral side effects. So practicing that excellent oral hygiene that your dentist taught you, you should continue doing. Brushing your teeth 2 to 3 times a day, flossing once a day, rinsing your mouth with with salt water and baking soda multiple times a day. Keeping your mouth as clean as you can will definitely help minimize the risk of infection. Some dentists may prescribe fluoridated toothpaste if patients are suffering from dry mouth. It's a slightly stronger toothpaste, and it's very mild, so it won't irritate the mouth. If you find that mint flavored toothpaste are irritating your mouth, you might want to consider non-mint flavored or fruit flavored. Believe it or not, some sort of fruit flavored toothpastes are actually less caustic, and I a lot of times recommend them to patients if they're suffering from mouth sores or mucositis. And avoiding alcoholic mouth rinses is of course recommended because alcohol can obviously burn your mouth and be very irritating to when you're undergoing treatment and are suffering from mouth sores. What about dentures and orthodontic appliances? Well, I kind of mentioned this before, but I would say definitely minimize wearing dentures during periods where the white blood cell counts are lower, because dentures are just kind of like a breeding ground for bacteria. When you're not wearing them, if you feel that you need to wear them, have them soak in an antimicrobial rinse. Obviously, do not wear them at night, but you shouldn't be, or sorry, when you're sleeping, not at night. But you shouldn't be wearing them when you're sleeping no matter what, whether or not you are undergoing therapy, because you always want to allow at least 6 hours for your mouth to breathe. As I said earlier, if you have a fungal infection, make sure that the dentures are also treated with an antifungal. If you have mucositis, avoid wearing the removable appliance when you have mucositis because that will just aggravate the mouth sores. If you're wearing braces, orthodontic appliances, it may be recommended that they're removed before starting chemotherapy, as braces are a harbor for bacteria. What about after therapy? Regular oral hygiene and recall visits are extremely important. So visiting the dentist, going for cleanings, checkups, etc. I usually recommend that patients see a dentist every 3 months, at least the first year, while you're getting adjusted to the changes in your mouth. The changes associated with chemotherapy in the mouth are, for the most part, not permanent. So that dry mouth, mouth sores, everything will go away once therapy is over. But it's still, while you're still getting adjusted to the changes and still recovering, I recommend seeing the dentist every 3 months, just so that you keep your mouth in good condition and don't have any problems. As for bisphosphonates and anti-resorptive medications, I cannot emphasize this enough. No dental surgical procedures should be avoided at all costs once you have started any of these drugs. And even if you go off of them, if you've gone off of them, I mean, give that information to your dentist. You can make an informed decision with your dentist together. But for the most part, I would avoid any sort of invasive dental procedures after taking these drugs. So just to review what invasive dental procedures are, those are extractions, implants, gum surgery. Non-invasive procedures are crowns, bridges, fillings, cleanings, and root canals and removable dentures. So once you start these drugs, non-invasive procedures are okay. Invasive dental procedures are not okay. Invasive dental procedures should be started or completed before these drugs are started. So I guess that's it. I hope. Does anyone have any questions?
Thank you, Dr. Levy. Thank you, Dr. Levy, for that presentation.
Oh, yeah.
Can you hear me okay?
Yes, I'm here.
Okay. Okay, there are a bunch of questions came in, so let me begin.
Okay.
Does treatment for necrosis differ for someone with stage 4 metastatic breast cancer?
As opposed to a different type of stage? Or I would say for the most part, no. Treatment is always pretty much the same. Usually treatment for osteonecrosis of the jaw is wound care. It's mostly non-invasive, so it usually includes keeping the area extremely clean, rinsing with a antimicrobial rinse that's prescription strength, and occasionally antibiotics may be indicated. The issue with the antibiotics and the reason that they're not always recommended is because sometimes, because the bone acts dead, the blood vessels in the bone are also not really working so well, and as a result, the antibiotic may not get to the site.
Great, thank you. If a cancer is not oral cancer, do you still recommend a dental oncologist, or is it sufficient to go to your regular dentist and make him or her aware of your condition?
I'm a little biased. I will always recommend a dental oncologist. However, if your dentist seems to have adequate knowledge about this, then it's of course okay to see your dentist. I guess I would say, depending on where you are, just make sure that your dentist is very much aware of your cancer therapy. Be your own advocate, and if you feel that your dentist does not know enough information, then I would go from there.
Okay, someone else is asking, after chemotherapy, my saliva has greatly diminished. Any advice on how to increase? I drink water all day long. It's very difficult to eat.
Okay. If you don't have a history of any sort of head and neck radiation treatment, and your chemotherapy is over, your salivary flow should come back. In the meantime, I would say keep drinking a lot of water. Unfortunately, sleep with a humidifier at night. Try rubbing olive oil on your gums and your soft tissues. That actually feels pretty good usually. If your dentist hasn't prescribed you a prescription strength fluoridated toothpaste, ask your dentist, because saliva is has natural protective effects against bacteria, and if you don't have saliva in your mouth, you're at an increased risk of getting cavities. So talk to your dentist about that, or start seeing your dentist more frequently. It should, though, come back. There are several salivary substitutes over the counter that a lot of people find very helpful, such as biotin, MedActive products, moisture. So I would say also try with those and see which one of those are, which one of those you like.
It's been 2 years since the end of treatment.
Well, if that's the case, then I would say that it's probably not just the chemotherapy that's causing the dry mouth, that it's probably other medications, in which case you might want to speak with your physician who's prescribing these other medications and explaining them to you. A lot of drugs can cause dry mouth, and some of them can cause severe dry mouth. So it's sometimes as easy as just switching one medication, and that might make a huge difference.
Okay, great. Another question. I've been on Zometa for 6 years, one infusion every 3 months, and I just started having soreness, clicking, and pain when I open my jaw wide. Should I be worried?
No, I mean, I would definitely go to your dentist, have your dentist take a look. But it sounds like you might be just suffering from a TMJ related condition, and it's probably, so I would go get that checked out. But it sounds like that's not, osteonecrosis of the jaw usually does not manifest like that.
Okay, good to know. Which washes have alcohol?
Most of them. Listerine definitely does. That's what the burning is from. ACT does not. Biotin does not. Listerine makes one that doesn't, but it's called Listerine Zero. And I believe Crest Pro Health does not, but Crest Pro Health stains. So I would watch for that.
Someone is asking that you comment on hyperbaric treatments to help with ONJ.
So hyperbaric HPO or hyperbaric oxygen therapy is usually more indicated or more spoken about when people are undergoing head and neck radiation and they may or may not be at risk for something called osteoradionecrosis of the jaw. Osteoradionecrosis of the jaw is actually very similar to osteonecrosis of the jaw, but it's associated with radiation, not associated with a drug. I'm not a huge fan of hyperbaric oxygen therapy. Granted, it's on a case-by-case basis, so I don't want to make any generalizations. But the thought process is that hyperbaric oxygen may cause blood vessels to grow, and if that's the case, then it may prevent getting this osteoradionecrosis of the jaw. But the studies are questionable, and although there's not really any hard evidence about this, it's more anecdotal than anything else, there is some concern that undergoing hyperbaric oxygen may awaken dormant cells. In other words, the reason that I'm not a huge fan of hyperbaric oxygen is that there are thoughts that it may awaken a cancer cell. Again, like I said, it's more anecdotal than anything else, so we don't really have that much evidence behind it. But we also don't know how helpful hyperbaric oxygen really is. But that's more indicated for osteoradionecrosis of the jaw, not so much for osteonecrosis of the jaw.
Okay. Is there a period of time after the cessation of deneuvem and chemotherapy when invasive procedures are okay? For example, after the half-life period is over?
Hypothetically, after the half-life period is over, that would be okay, but because we know so little about these drugs because they're so new, I would still avoid the dental invasive procedures to be safe until we learn more about them since they're still so new.
Okay. Someone is saying that they had osteonecrosis. It was treated with surgery. Should I stay away from Exgeva in the future? My dentist thought it was not the cause. My oncologist had me stop Exgeva.
I would never recommend, or I would never advocate for someone to stop a drug that may be helping their cancer because of a dental-related condition. I would just say in the future, don't do any sort of dental surgical procedures, if that makes sense. Like if the Exgeva was helping with the cancer, that's obviously really important, and I wouldn't say to get off the Exgeva, but just, don't have an extraction in the future, don't have a dental surgical procedure, etc.
Right. If you've been diagnosed with osteonecrosis, is it okay to wear a night guard?
Yeah, I guess as long as it's not aggravating the condition, sure, it's okay to wear a night guard.
And someone is saying that they've been prescribed a mouthwash that has alcohol in it. Should they continue to use it?
If it's not bothering your mouth, that's fine. I more just don't recommend using them because using a alcoholic mouthwash because it can be very irritating if you're suffering from mouth sores or mucositis.
Someone is asking if you've noticed any relation to Taurus, and does this additional diagnosis have any impact?
Did I notice any relation? You mean if you have tori, is there an increased risk of getting osteonecrosis of the jaw? Maybe that's the question. There's not an increased risk. It can unfortunately occur spontaneously. So you could accidentally eat a chip and cut your torus, and then I guess you could hypothetically get osteonecrosis of the jaw. But no, I don't think that there's. I don't. I would. Yeah, I don't think. Otherwise, I would just. Yeah.
Okay, I have some other questions here. I'm just sorting through.
Okay.
I've been on Zometa for 2 years. How concerned about mandibular degeneration should I be?
You've been on Zometa for 2 years. It really depends on the amount of doses that you've had. Like I was saying before, it's not only the duration, but it's also the number of doses. I would say as long as you visit the dentist regularly, keep your mouth in good condition, avoid any invasive dental surgical procedures, then you shouldn't really be that worried, but just always keep in the back of your mind and always inform your dentist that you're on that drug so that the dentist isn't like, oh, let's take this tooth out, or let's do an implant, or let's do some sort of bone surgery. So all of those things want to be avoided, and that's as long as you go by that mindset, I wouldn't be that concerned.
Great. And someone else is asking about oral side effects from long-term use of aromatase inhibitors like letrozole.
Are they suffering from these side effects, or?
I'm just kind of curious if they can cause oral side effects.
No, I haven't really seen much side effects with those.
And someone is asking, is deep cleaning okay?
I would avoid a deep cleaning. A regular cleaning is okay, but I would say I would not get a deep cleaning if you're on these drugs. If you're on the bone strengthening drugs, do not get a deep cleaning. If they're doing what they call scaling and replaning, that should be really done with caution or just really not done, because if that's inducing a lot of bleeding and they could be scraping away your bone, that could cause a problem.
And is ONJ associated with Xgeva in all of its forms, infusion and pills?
Yes, it is associated with all of its forms, but you're at higher risk of getting osteonecrosis of the jaw associated with IV bisphosphonates than oral.
Okay. Can you discuss the use of dexamethasone rinse for mouth sores?
Dexamethasone rinse for mouth sores can be very effective. It's just a steroid, so as long as you're taking it topically, there's really no. I mean, that can be very effective. I don't necessarily recommend that first. I usually recommend something more like I was saying, just like more of a palliative mouth rinse, like a magic mouthwash or something like that. But dexamethasone, but if none of that is working, then dexamethasone can be a very effective treatment.
Someone is experiencing cycles of blisters on the corner of the mouth and occasional blood blisters inside the mouth. They use hydrogen peroxide and baking soda on teeth. This is the only thing that seems to work. Is this causing more issues?
Using it's a little hard for me to say without being able to see, and do an exam myself. I guess if it's working, I can't imagine that it would be causing more problem. I mean, hydrogen peroxide can actually sometimes interfere with healing, but if it seems to be helping, then it's really hard for me to make a definitive statement without an exam, unfortunately.
Okay. And someone is asking about the risk of oral cancer with Doxil.
What's the question?
Is there a risk of oral cancer with the use of Doxil?
I mean, I think that's as far as I know, I don't really know of that much of a risk about that, so I would not worry about that. But I don't really know that much of the literature regarding that, to be honest.
Okay. There's been some information in the news lately, or at least on Facebook, about root canals causing breast cancer.
Yeah, that's ridiculous.
That?
Yeah, I don't. Yeah, see, that's the thing. Yeah, some of these things I don't know where they get this information from. I don't know where that information is from. I've seen it, but I don't know why that's gotten any sort of press, and I don't think there's any true studies that confirm that. So I would ignore it and not worry about it, honestly.
Okay, it looks like we only have a couple more questions. Someone is wondering if there are any resources nationally to help women with dental work. Are you aware of any?
To help women with that. Unfortunately, no. I mean, I guess you can Google, and by looking stuff up on the internet, you can find a lot, but unfortunately, I don't know of any national resources.
Okay. And Cher may have that information. We have a 600-page resource guide that may contain some of that information, so people can just call our helpline and ask about that. And let's see, the last question is, how do you preserve your teeth from yellowing?
I would say regular cleanings for sure. Occasional, if the regular cleanings are not keeping your teeth white enough, then of course you can get in-office bleaching, or you can do take-home. There are several bleaching agents that you can buy: Crest White Strip, Tray White, the opalescent trays, using a whitening toothpaste, that sort of thing.
Great, and I think that's it. I think I've gotten through most of the questions. Let me just double check. Someone is asking, what's the actual half-life of deneuvem?
I think it's like, I want to say around 7 years. Let me just verify that before I make that statement. I'll tell you right now. It is, let's see, hold on. I have this written down because I figured this would come up. Okay, so this is saying that it's only 30 days, but I don't. That's why I was still not. Okay, so according to the Prolia website, Prolia is claiming that it's 25 days. But I still, even knowing that information, I would still be wary that even if you stop denosumab, to jump on the bandwagon and get a to get dental surgical procedures because unfortunately I have seen osteonecrosis of the jaw. So even when they've stopped taking denosumab, so I would still, I mean, it's good to know this information, but I would still kind of, proceed with caution if you were going to stop denosumab and then undergo a dental surgical procedure.
Okay. And just one last clarification question. What drug category is Xgeva?
I would call it an anti-resorptive medication.
Great.
But it does not work the same way that bisphosphonates work.
Okay. Do you want to elaborate a little bit, or?
Sure. I mean, it's a little complicated, but basically, it doesn't really bind to drugs. It's an anti-rank L inhibitor. So it's basically your body produces all these different sort of the way the bone cells work, or there's like a few different types of bone cells, and bone is constantly remodeling, leaching out calcium, or putting calcium back into bone. And basically, the way that denosumab works is it kind of it inhibits the way that a certain type of bone cell matures. I guess that would be the simplest way of describing it.
Great. Okay, I think that finishes our questions. So, Dr. Levi, thank you so much for an informative program, and thank you all for participating. If you wouldn't mind, just take a moment to fill out the survey at the end of the webinar, and check out sharecancersupport.org. We have another webinar later this week with a report back from ASCO with Dr. Don Dizon with an emphasis on metastatic breast cancer. And you can see that on sharecancersupport.org. Dr. Levi, thank you so much. Really appreciate your time.
Yeah, great. Thanks so much for having me.
Thank you.